So good evening, everyone, or good morning if you are from North America. It's our pleasure today to welcome you again with our series of webinar with the Dubai Shoulder course in cooperation with the Emirates Orthopaedic Society. We have today two speakers from two different schools of medicine. One from the North American school, Shariff Bishai, and the other one from the British school, Matt. Our subject today will be about the AC joint dislocation, the acute and chronic management. The program will start with me. I will present one of the cases. Then Shariff will give us a nice presentation about how he managed the acute AC joint separation. And then we'll finish with Matt. He will show us how he's dealing with the chronic cases or AC joint reconstruction. It's my pleasure today to have Shariff. I met him a long time ago while I did one of my advanced shoulder courses in Chicago. He was the instructor with me at that time. It's a couple of years before. Then he visited us here in Dubai with the last Dubai shoulder course. So Shariff is a shoulder and sports injury surgeon working in Detroit in Michigan. He did his basic training, orthopedic surgery residency at Henry Ford Hospital in Detroit, Michigan. Then he did one of his clinical fellowship in UK. He is a fellow of the American Osteopathic Academy of Orthopedic Surgeon, and he is the fellow of the American Academy of Orthopedic Surgeon. He is serving as an associate professor for Michigan State University College for Osteopathic Medicine, and he is also associate professor for Auckland University Hospital School of Medicine. And finally, he is a professor at the Detroit Medical Center for Sports Medicine. Shariff, welcome with us today.
Thank you, I appreciate it.
Our second speaker, Matt. He's a well-known shoulder surgeon in Manchester and in UK generally. He did his basic training in UK, and then he did one of his fellowship at UK Upper Extremity Fellowship under the supervision of Mr. Steve Copeland. Then he moved to North America, did one of the North American Fellowship at Mayo Clinic in Rochester, Minnesota. And then now he's back to practice in UK. He's a very well known in teaching shoulder surgery, arthroscopy, and arthroplasty all over the world. Welcome, Matt.
Thanks, Usama. Thanks for the invite.
Thank you. So guys, I'll start sharing my screen. I'll share with you a quick case right now. So guys, I'll start with you with one of the cases. So this gentleman is 42 years old. He's right-hand dominant. He's working as a pilot. He's non-smoker, medically fit person, very active. He had a fall from a bike. It was a road bike, and he hit his shoulder. The common scenario for AC joint separation. That's his initial X-ray. AC joint dislocation, looks like type 5. So he went to one of my colleagues. He advised him for an AC joint fixation. The surgery was done exactly 7 days from the injury time. He did for him an open fixation. He did a CC fixation using a dog bone button, and he did an AC joint fixation or internal bracing using 2 anchors. That's the initial X-ray post-operative. Looks decent to some of us. Then post-operative, he had a rehabilitation for 3 months, back flying on 4 months exactly from the injury. On his first flight, after he landed, he was carrying his bag, going back to the hotel, and he felt snapping in his shoulder, deformity and pain. And then presented with this X-ray, unfortunately. So he's back to the same surgeon. exactly 4 months from his index surgery. Pain was 4/10, according to the report from the previous surgeon. Range of motion was full. There was some deformity and mild tenderness over the AC joint. Then he advised him, just wait and see for a conservative treatment. 1 month later, he came again. Pain is still 4/10. It's not severe pain, but he has now limited forward elevation and abduction. And there is a deformity, still deformity. It's going on. And there is a tenderness over the AC joint. So Shariff will tell us exactly in his presentation or give us some clue why it did fail and what he would do differently in this situation to avoid the failure, and give us some information. What next? What we should do next? Then revision surgery done, open revision surgery. He removed the clavicular button. He reconstruct using a CMT graft from the contralateral leg. And that's the immediate X-ray post-operative. So there is 2 tunnels there on the clavicle. And he removed the internal bracing or the dog bone button from the clavicle. November, 3 months later, ended up with this one. And it's not only deformity, it's the range of motion. Look at his range of motion. Very limited. His job needs overhead activity and he cannot do it. That's why he's been grounded for more than 9 months. So with the presentation of Matt, he will give us some clue why it did fail, what he would do differently to avoid this failure, and we will discuss later on any further images we should do, anything differently. If we going to revise him, what is the graft choice and the fixation choice? So I will leave the floor now to our 2 guest speakers, and we will come back to the case to discuss and to see what we could do, what we could offer the patient. Thank you. Shariff, you can share your screen now.
Thank you for the introduction. And that's an interesting case. And so we'll start today. I'm going to go through the acute injuries. So I'll take a little bit of what happened initially on, and then I know Matt will finish up talking about the chronic stage. So when we look at AC joint injuries, I want to just start simply, just go through a little bit of the backstory of these. And so the mechanism is usually due to trauma. And in this case, it was a fall off a bike. Now, we need to understand the anatomy of the AC ligaments, and that those will deal with the horizontal stability, the anterior posterior, whereas the CC ligaments are more of the vertical stability and the superior inferior, and then obviously classifications and then treatment. The ones that's most where we don't know exactly what to do, except if we really take into consideration that particular patient is the type 3. How do we figure it out initially? Well, we look at our radiographs, and it's important to tell your technician that it's going to take about 1/3 to half the X-ray penetration to get a good film. Otherwise, it'll be over-penetrated. More common, you're going to do the Zanka view, which you see here on the right, which is a little bit of a 10-degree cephalic tilt. And then the axillary view is going to help you figure out anterior posterior. Don't forget that one, because more often than not, we get stuck looking at how superior that bone is, that clavicle is, as compared to the acromion. But it's also important to understand where it is in space, anterior and posterior. And so the stress views are rarely used today. I mean, for me, if you think about it, the patient's already in pain. Now I'm going to tell them to carry 10 pounds, and it's not going to give me much more information. So I think for me, the stress views are unwarranted. So with classifications, Allman and Tossi initially came up with the first 3, and then Rockwood added 4, 5, 6. And why these are helpful is, I think, just with any classification, is what is your treatment plan going to be based on your classification? So again, starting with the type 3s, your AC ligaments and CC ligaments are going to be disrupted. You're going to have about 25 to 100% superior positioning of the clavicle to the acromion. Type 4s, these will go posterior, and these can buttonhole through the trapezius. The deltoid and trapezius muscles can also be detached from that deltoid as well. The type 5s, these will also, type 4s, we discussed type 5, it's nothing more than a type 3 with more displacement. So instead of being 25 to 100%, it's about 100 to 300%. These are very easy to diagnose and very easy to discuss with patients because these will do better with surgery. When we're talking about these, the treatments, type 1, type 2, type 3, if you're going to go with conservative, are very simple. You put them in a sling, you just ride this out, conservative treatment, physiotherapy, and then once they restore their range of motion, function, strength, they can resume normal activities. The type 3s get a little bit more controversial, and these are going to be more of your laborers or high-end athletes or throwers. These are the people that need that overhead just in this particular case we saw. And then 4, 5, 6 tend to always be operative. So again, what are the non-operative treatments we just discussed? And so we're going to go into a robust conversation today regarding operative treatment, from the primary fixation to primary CC ligament reconstructions with or without an allograft or autograft, excise versus don't excise the distal clavicle, or even possibly some muscle transfers. I think it's also important to note that this is one injury in the shoulder. In the Scheibel article, 40 patients looked at with type 3, 4, and 5s at over a year, arthroscopic AC repair in 26, open repair in 14. But what was interesting about this is the traumatic intra-articular injuries in about 15% of these cases. So it's important to also note they might have other trauma. For me, I do get an MRI on these patients in order to see what else do I have to treat, if anything. But in this particular case, are these acute or chronic injuries? I mean, did they have these slap tears or postal lesions prior to their AC separation? So they actually looked at these patients in a different way. It is a level 4, but it is prospective, 125 patients, all the way from type 2 and all the way to 5s. And they looked at these, and what they found is more of the acute lesions were the pastas, injuries to the anterior pulley or the long head of the biceps, and slap injuries. But it was unclear if the articular-sided partial subscap tears were from this or were those from a previous injury. So it is beneficial to understand that there are going to be concomitant injuries and be prepared to take care of those as well when you take care of the AC joint. And so when we look at AC joint instability and how we're going to fix them, there's anatomic, there's non-anatomic, and a different type of non-anatomic we'll get to. So the anatomic is going to be to reproduce the conoid and trapezoid ligaments with a graft or non-absorbable suture. The non-anatomic in this particular is single CC ligament technique versus the ORIFs like you can use with plating. So there's different ways to do a non-anatomic, and we'll go through that as well. So I did this on purpose, and I made a very busy slide because I want to show you how many different ways over the years there's been write-ups of the ways to fix this, all the way back to 1861. And more recently with Mazaka's work of doing an anatomic CC reconstruction. If you look right now, there's about 151 surgical procedures in the literature for this particular problem. So what that tells us is we really don't know which one's the right one, but there's a lot of different ways to skin this cat. So today we'll talk about a few of them. So when you, Ashish Bedi had a very nice article looking at a lot of different ways and looked at the Bosworth screw all the way from 1941. In some of these studies, they showed upwards of 95% good to excellent results, but they also, in a different study, showed a 32% failure rate. The ones I've seen anecdotally, many of these will pull out and the screw will come out of the coracoid, and it's also concerning how big that hole is in the coracoid for the possibility of a coracoid fracture. The hook plate's been around for years, but one of the issues with this, it can cause impingement, acromial erosion, a loss reduction, or even hardware pain, and it does require a removal of hardware. But what's nice about this is when you're running out of options, this is a great way to help you fix it. CC ligament cortical fixation, again, wherever you read, it's dependent on the particular authors. In the first study here, it's 96% satisfied, which is, excellent, of course. But in Scheibel's, he said 95% had an increase in their constant scores and did very well in their subjective shoulder values, but still had posterior instability in about 43% of patients. So the cortical fixation, we'll talk about in a little bit. If it's done single versus double, does make a difference, because we often, again, only concern ourselves with the superior inferior, but it doesn't really help with the posterior and anterior stability, which in many cases is the reason for recurrent pain and instability, not necessarily that the clavicle is still sitting superior. Again, 62% subjective sport-specific AC integrity was seen in 42 patients, and then another one showed us in 116 patients about a 27% complication rate. So the numbers are essentially all over the map. Looking at ligament reconstruction, the original Weaver-Dunn procedure, initially 75% good to excellent was seen. Harris looked at this biomechanical study and looked at the anterior-posterior issues and found that Weaver-Dunn did not restore the anterior-posterior stability. Using auto or allograft CC ligament reconstruction, Mazaka popularized this as well. And they're starting to realize maybe this is the better route to do it anatomically. So these biomechanical studies done by Mazaka, and one important thing to look at when you compared a 2-bundle arthroscopic CC ligament versus a 2-bundle anatomic open CC ligament reconstruction, and then the modified Weaver-Dunn. The modified Weaver-Dunn had significant laxity compared to both the CC reconstructions, whether open or arthroscopic. They didn't find any differences in the bone density, the load to failure, and cycling this with superior migration of over 3,000 cycles. The anatomic CC ligament reconstruction open had significantly less anterior and posterior translation. So there's something to be said about doing something where there's a front and a back part of this, such as when you drill the tunnels, which we'll get into, to restore that stability. So the failure to reproduce the AC and CC ligaments may lead to recurrent pain and instability. So in 2010, Mazaka published this, a case series of 22 doing it this way with the anatomic. ASES scores went up significantly, as did the shoulder scores, and constant improved by 66. He did have failures, 1 persistent pain, 1 chronic infection, and 1 loss reduction. How he did this is he went, made an incision from the AC joint to the coracoid, and through that he was able to wrap around the ligament around the coracoid, and then he would drill his 2 tunnels, 1 posterior medial, 1 anterior lateral, to represent his conoid and trapezoid ligaments respectively. He also would use a non-biologic, in his case he used a suture tape around this, and he did that in a standard U versus crisscross like he did the ligament. He also took a distal clavicle excision, but later he decided he would save the distal clavicle. And one of the issues that has become more popular recently is the reconstruction of the AC ligament. And you can do that with the remainder of the graft or the remainder of whatever you're using to come up and over and across that AC joint after reduction in order to reproduce that AC joint capsule. And then over that, you would fix the fascia. So looking at this, Heinz Honicke in San Diego looked at this with his group, 3 CC ligament reconstruction techniques. One was a coracoid loop where he wrapped the suture around. One was single bundle and one was a double bundle around. What he found was that the cortical loop and the single bundle had less internal scapular rotation stiffness. They were a little looser, which makes sense. We've talked about it didn't control the AP stability. The loop, as well as the single bundle, allowed more posterior clavicle rotation, which again leads to instability, but all had a decrease in the external scapular rotation and anterior clavicle rotation. So the conclusion was the double bundle reconstruction gave the closest, but not always the same as the CC ligaments during internal scapular motion as well as posterior clavicular rotation. And that's going to offer the most stability in that horizontal plane, which tends to be the most problematic in post-op instability. What are the complications when something like this happens? A lot of it has to do with position of our tunnels. In some of these different techniques, we have to drill through the base of the coracoid so we can see coracoid fractures. And then, of course, loss of reduction in many of these. So again, in these particular groups, cortical button fixation versus a tendon graft, 23% in the cortical fixation group, and with the tendon grafts, we saw about 28%. So we need to do a better job. How do we do that? Because it's hard to say 1 in 4 of these is going to have a complication when you're talking to your patients. So with the clavicular bone tunnel malposition, that's important. And I'm going to let Matt get more into that because he's going to be talking about the chronic cases. But the more medialized you make your tunnels and you're off the position of where you want to be, that is where you're going to have early failures. If you have these ratios, meaning what they did in this case, in this study, was measure the distance from the lateral aspect of the clavicle to where the conoid was positioned, and if it was less than 0.25, they had no failures, but if it was greater, then that's when they saw many of these as quickly as 7 weeks post-op. So pearls and pitfalls, you want to position these in a position where the tunnels are in a proper position. You want to maintain full thickness flaps of tissue so you don't have issues with skin and healing of the fascia over it. We want to keep our tunnels greater than 20 millimeters apart to avoid a fracture. And then we want to keep our tunnels at least 10 millimeters from the AC joint, and then use the smallest possible tunnel. So the smaller we can get something in there to somewhat give us our CC ligament reconstruction, the better. So 5 millimeters is probably the limit of where you want to be. So here, some other options. So as we've learned, some people have taken it into their own hands to try to figure out maybe a slightly different way. So if you look at this top picture on the right, you see that it's almost buttressed because they went through the AC joint back around. Oops, excuse me. And in doing so, they used a palmaris longus. Here in the States, we would probably use something else like an allograft. But what this did was it brought this down, pushed it down, and brought it down with sutures as well. And what this did is the upward force was on the acromion, the downward force was on the distal clavicle. Advantage, it's simple. It avoids working around the coracoid. There's no metal, there's no second surgery to take out hardware, but the disadvantage is that it's non-anatomic, and it really only fixed the AC joint. It did not fix the CC joint ligaments at all. So review of some of these. What are some other options? Well, we've been talking about using ligaments and such, but why can't we use some synthetics like a polyester Dacron? This has been described since 1974, and the graft is looped around the coracoid, passed through the clavicle, and sutured. In this particular study, the OR ranged from 7 days to 8 years, and the average follow-up was about 2 years. All good to excellent results, good stability, good range of motion, and patient acceptance. Cybex testing showed no significant weakness. So when you look again on these using sutures, and what they did in this particular case is they drilled through a couple tunnels, grabbed the CA ligament, so kind of like a Weaver Dunn, brought it up and through and attached it with anchors. Advantage, very low cost, which is very common to be a concern here in the States, but no hardware failure. Arthroscopic perfusion was unnecessary, no donor site morbidity. Disadvantages, it is an open procedure with a larger exposure, and it is, again, non-anatomic. So using a 6-strand polyester suture and a cortical button, so using two different dog bones, can be done arthroscopically with a small incision over the AC joint, or excuse me, over the distal clavicle. What it did here is it did not do anything with the AC joint. There is no collagen with these particular techniques. How about an anatomic joint reconstruction with semi-T? So just like the last one, but adding a graft. And in this one, you loop the graft around the coracoid. And we wrap this one up and around the clavicle. So the actual ligament does not go through bone. It goes around the clavicle and around the coracoid. So it's a big loop of soft tissue on top of this. And here there's disadvantage and potential for the allograft complications and clavicle fractures. Anatomic allograft fixation with a button tape construct, no drill holes in the coracoid, and a single small drill hole in the clavicle. So anatomic CC ligament reconstruction for acute. And again, this is one that we're going to come back to. I apologize for the busy slide, but there's a lot of interesting information in this one. The C-tap angle, which is the clavicular tunnel anterior posterior. It's a particular, our goal is to make the two tunnels parallel. The more that those two are off, the more likely you're going to have a failure. So if we look back, when we go back to the case, you'll see that those two tunnels were sitting with a pretty acute angle as compared to them trying to be essentially on top of each other. And that leads to many of the failures. So the lower that C-tap angle is, the more favorable the outcome. So I brought this up, the Leeds-Kyle ligament. So this ligament has been around since the 1980s. It's not really a ligament. It's a Dacron polyester blend which is a scaffold, and it was used significantly for ACLs, but it's starting to show other options now. There's significant data on this, which shows that it's very strong. It has very ligament-like properties and actually allows for ingrowth. So in many situations, you may be able to do something without the cost of an allograft, without the comorbidities or donor site pain of an autograft, but get very similar outcomes. So in a human study, 57 patients, 16 to 66 years old in Tokyo, they used it for an ACL and found that many of these had when they looked at the graft, they found vascularization with arthroscopy at as little as 4 months post-op and no evidence of synovitis or degenerative changes. And a very strong graft, as you can see here on the right. And when they went back and looked, they found that it was very similar to the tissue that they would have expected to see from real tissue because of the ingrowth. At 3 months, they found some immature tissue, but dense vascular networks. By 12 months, new ligament had developed, and it was very similar to a natural ligament. 18 to 24 months, it had a very similar appearance to an ACL and no significant complications. So I know we're talking about AC joints, but I'm talking about the ACL. But why I'm doing that is because over the last few years, there's been new talk of using open weave technology in these Decron or polyester grafts, which in this particular study, you can see there's collagen fibers that were very normal to the ACL, and 95% had an average cross-sectional area very similar with collagen, and only 5.12 of Decron fibers left in this. So it ingrows, which is very nice to see. Histologically as well, it looks very similar to normal tissue. So why that's important and why I'm bringing that up is because this may be the next generation of repair and reconstruction using something like this, for this particular item, where you go around and loop it through the clavicle, or excuse me, around the clavicle, and up and over the clavicle. You can do it with or without making a hole in the clavicle. I've recently used this and went up and across with the acromion, going back down another tunnel in the acromion. So there's a lot of different ways to use this. And when you look at this histologic report that Matt supplied us with, you can see that it looks like explanted ligamentous tendon type tissue. So that's really exciting to see. So without having to use a graft, we might have an opportunity to use something that is going to be helpful to reconstruct, but also be strong, stable, cost-effective, and without donor site morbidity or even additional costs for a graft. And with this open weave technology, we can see here, it's very high strength. It comes in different sizes from 10 to 50 millimeters. It's very long so that you can go up and across and span the AC joint if you'd like. Here you see it in some of the other applications, again, within ACL. So again, very, very strong. It's tried and true. It's been around for 40 years. It's actually the same polyester blend that are used with cortical fixation in ACL. So it's not something that we haven't used in the body. We use it all the time. Over 3.5 million implants in these cortical suspensory fixation buttons. Again, different blends, different sizes, and with those, it allows for this ingrowth. So this might be another opportunity. I know Matt and I are very happy with this so far. I'll let him talk a little bit more about it here in a few minutes. And again, when you look at it under a microscope, again, seeing very good results, and rapid cell adhesion, cell response to this, lays down new tissue, and as it matures, it becomes ligament-like. So in our final thoughts, now this is not the end. It is not even the beginning of the end, but it is perhaps the end of the beginning, Sir Winston Churchill. So I think that's where we are with AC joint reconstructions these days. Thank you.
Thank you very much, Sharif, for the nice presentation. We will move on with Matt to present his way of how to reconstruct the chronic cases. Matt, are you ready to share your screen?
Yes, I'll share my screen now. Okay, so again, thanks Usama, and thanks Sharif for sort of covering a lot of the sort of data behind what we're talking about. And there's an awful lot of studies out there, and equally, as Sharif said, there's 150 odd ways of doing this procedure. So in my mind, I kind of think that means there's no one perfect option. If we'd have had a perfect option fixing this AC joint dislocation, we wouldn't have had 150 different versions of it. So clearly, you know, there's lots of things around there. And I'm going to talk to you about what works best for me. I'm not saying it is the perfect thing, but it is definitely what works best for me for chronic AC joint dislocations. And I do have a financial interest on the Kairos Infinity Lock. So back in the UK, you know, our main sport, the collision sport, is rugby. So this is our common injury. You know, the guy gets sort of pile driven onto the floor, onto the shoulder, and then dislocates the AC joint. But also commonly for us where I live, cycling. You know, cycling is a very common sport, and it brings us, you know, a handful of cases every week. Interestingly, Shariff mentioned about the classification, and I'm not a big fan of classification systems. And my colleague Len Funk in Wrightington essentially used all the shoulder guys in Manchester to try and validate this classification. So he sent us all 24 x-rays of shoulders with AC joint dislocations, and he told us all about how to classify them based on the Rockwood and the Elman classification system. Then he asked us all to classify them. So we all dutifully classified them to what we thought was correct based on those films. And then a month or so later, he sent us another load of x-rays and asked us to classify them again. What we didn't realize, they were exactly the same x-rays, but just in a different order. And what one surgeon classified the first time, a month later, they classified it as something completely different. So there was really no intra or inter-observer correlation. So in other words, it's not a great classification. We've heard a lot about the surgical options from Shariff, and I'm really going to concentrate on those chronic ones. And but just a small point, you know, what is acute and chronic? And it is different depending on where you're looking at it. For some of the endo button fixation techniques, such as the Storts and Minar, if you're using just the buttons and the tapes, they're not licensed for anything over 2 weeks unless you use it as an augmentation device to another graft. So if that's your classification of acute and chronic, then 2 weeks is the cutoff for not using something that's got a more biological activity to it. So the tapes are only the first 2 weeks. And of course we've heard about the transfer, we've heard about, you know, screws and things like that. But, you know, there are some problems with them. And K-wires, I'm really not a fan of K-wires. If you look at the x-ray in the top there, this is a patient had a K-wire fixation, so trans AC joint, and the wire broke and ended up coming out through his spinal cord in his neck. And the bottom view is, again, an interesting way of fixing an AC joint. It's using essentially like an Alizarov type frame on top of it, which is, again, interesting and probably very uncomfortable for the patient. And again, we've got better techniques now, as Shariff mentioned. You know, these things are, you know, probably should be we shouldn't really see them in the museums now, rather than actually using them in patients. So as Shariff said, you know, I have got some interest in this, and I've been working with this company now using open weave tapes, and so we've got a vast amount of experience in the UK, because essentially we use them in the UK because it's quite difficult for us to get grafts. So we've gone very much down the synthetic route rather than more the American model, which would be using a graft augment. And with this system, you essentially loop around the coracoid. And I like looping around the coracoid rather than drilling through the coracoid. I think if you drill through the coracoid on some of the devices, if you're slightly off-center drilling, then you're going to get coracoid fractures and the button flips around and things like that. So yeah, I go round the coracoid and then up through the clavicle. You can go through the clavicle, you can go over the clavicle, you can use the tapes to go over to the acromion, as Shariff said. But interestingly, independently, I haven't seen Shariff's talk, but the tunnel placement is the critical thing for your procedure. And it is all about the distance from the unresected end of the clavicle. Depending on where you make your incision, if you go straight over the AC joint, your tendency is that your clavicle hole will be very lateral. It will be within 10 millimeters of the end of the clavicle, of the unresected end. So you actually have to go a lot further over. So my incision for these, I'm doing an open, is not over the AC joint ligament. It's kind of much more medial to that. Because if you look at anatomically, where the CC ligament attaches broadly is around 3 centimeters from the unresected end of the clavicle. And you see on these two x-rays here, if you have a vertical drill hole, then you have a fixed length of whatever product you're using, sutures, tapes, open weave tapes, you have a fixed length of material between the undersurface of the clavicle and the coracoid. If you have, as on the left-hand x-ray, a very oblique sort of tunnel placement, then essentially you have a longer length of material between the clavicle and the coracoid. And all that happens is it's like the hypotenuse of a triangle. All that happens is that will want to assume a vertical orientation because of the stresses, and you will lose your reduction. But if you go in line with your drill hole through your clavicle, your drill hole through your coracoid, then it's much, much less likely you're going to get loss of reduction. And this is a video that I've done with Kairos, and you can see it's in a draft version at the moment. And that's about to sort of, in the next 2 weeks, be published by Kairos over in the States. But if you see here, I've got a tape measure, and you look where the coracoid is underneath clavicle, and that's 3 centimeters, and 3 centimeters takes me directly over the top of the middle of the coracoid. So not there, which is 10 millimeters, which will give me an oblique angle orientation, but I want to be vertically orientated over the coracoid. And you'll see now when we've got the ligament in place, and again, it's whatever ligament you use, it's more importantly is these drill hole positions. The one that I've designed, you come up through the clavicle, and when you pulled your tapes through the clavicle, you'll see here now that the loop around the coracoid is as far towards basically the base of the coracoid you can go. That's very important. And my drill hole is in line with the knot on the ligament. So this is a perfect sort of in-line position. It's not an oblique position. So when I tie this down, I'm going to have a nice construct. And then, as Shariff said, I'll use my tails and I'll go over to the acromion. Open versus arthroscopic. I think, you know, it's whatever kind of, sort of however one you take your pick, really. The important thing about the arthroscopic one, it is the operation I'm sort of favouring is an arthroscopic assisted. It is definitely not an all arthroscopic operation. 10 years ago, I used to do sort of an all arthroscopic endo button fixation, and I had quite a few fail because I wasn't addressing the deltoid trapezial fascia over the AC joint, which is incredibly important. So even if you do an arthroscopic procedure, you still have to address the AC joint ligament and the deltoid trapezial fascia. If you don't, then you'll have failures. So if you are going to do it arthroscopically, I do arthroscopic latiges and arthroscopic bone blocks. And these are my ports I use. And I learned this T from Mark Gettelman over in Skokie in California. And this port, the lateral port is over your subscap. And you have a very high rotator interval port. And if you draw a line between those two ports and halfway down, bisect and go away from it, this sort of inferior port here is a perfect position for passing around the coracoid, getting a really nice view of your coracoid. And you'll see from this view here, I do it slightly, I do it slightly more simply now. But here I'm looking in from the side of the shoulder. This is a right shoulder. In front of me, slightly to the left, is the end of the coracoid process. This is now looking through the rotator interval subscapularis, the joint. So I pass the tape under the coracoid, conjoint tendon still intact. Then I just retrieve it over the top of the coracoid, and I've left the CA ligament intact and made a little window behind it. And essentially now you just pull the infinity lock through. So this is the arthroscopic pit. It's just an arthroscopic assist way of getting the tape around the coracoid. And I'm still going to open over the AC joint to reconstruct the deltoid trapezial fascia. And as mentioned before, that's a very important part. When you drill through the clavicle now, your clavicle essentially will drill straight onto the top of the coracoid. So now this is looking back underneath the coracoid from the joint. I can see the ligament sitting nicely. This wire here now is coming straight through the middle point of the clavicle, about 3.5 centimeters back. And you see it brings me directly over the coracoid. And it's going to, the knot is pushed to the side at the moment, but as we then bring the sutures, the limbs through, that knot will flip over to the top of the coracoid, and it will mean my tapes will be vertically orientated in line and directly over the coracoid, reducing that risk that I'm going to have a longer length of tape, which is essentially going to stretch out, and I'm going to lose my my reduction. So as we pull now on the tapes, I'm reducing the clavicle, and then I'll do my fixation over the top. And essentially that's the only arthroscopic bit, because I'm still going to do an open repair, as I said, because it's incredibly important to have that open part of it. As Shariff said, do we need biology? Well, in the UK, my answer is no, I don't need biology. I don't need to add a graft into it. If you look at a braided tape, braids are very, very dense. And in a braid, you only ever get on growth. You get no ingrowth at all, as you can see from the histology on the top. The open weave has these little holes in it, and the size of the holes is crucial for dictating ingrowth. So we get ingrowth and on growth of tissue. And the tapes are very strong. So if you look at the normal native CC ligament, 500 newtons for ultimate tensile strength, and the ligament I've just been talking about is 2,500 newtons, so 5 times the strength of a native ligament. So I don't need to add a bit of semi-T, allograft or autograft, because I know I'm going to get ingrowth up this ligament. So I've got initial high strength, and I'm also going to get biology into it as well. So coming to the end, really, timing of surgery, there's no real difference in outcomes. Do you excise the lateral end of the clavicle? Well, the literature says it doesn't matter, but however, I found in my series, when I've excised maybe too much clavicle, maybe 8 millimeters or so, I've lost reduction. And I think when you take out too much clavicle, you probably destabilize the AC joint and the ligaments around it. So now I really try and not excise the lateral clavicle at all, unless I need to, because I can't reduce it in a very chronic or a type 4 where it's gone backwards. But as mentioned, the oral arthroscopic technique does not address the DT fascia, and that's very, very important. So what works best for me? Essentially, you've got to speak to your patient. Do you want this acute injury fixing now, and then you're kind of done? Or do you want to get back to work, but then maybe it's 6 weeks down the line, you may be having pain, trouble overhead, and then you're going to need an operation potentially and more time off work. So it's very much do you have 1 hit or 2 hits off work? And that's the discussion with your patient. And often for me, in chronic cases, it's function and cosmesis. People just don't like a clavicle that's sticking up, it interferes with certain t-shirts and for ladies bra strap area. So there is a cosmetic element to it. So if I'm going to do surgery, for all cases, I'm going to use the Infinity-Lock. But as mentioned, I do have a financial interest in that. But I use it for acute chronic fractures, and it works very well for all those. And it's, go medial with your tunnel, so you have a vertical placement, fully repair that DT fascia. And then post-op, that's my standard regime for all sort of AC joint work. Sling for a couple of weeks, waist height, then chest height, but nothing over shoulder height for the first 6 weeks. But don't beat yourself up, because you can do great surgery. And the case that Usama's going to show you, I think he's beaten himself up a bit, but he's done a great job in the end, and we'll see that in a minute. But Len showed me his results of the LARS, and he had a very good reduction, but they all slipped a bit. And he lost between, you have a 9 millimeter gap, and he was losing about 4 or 5 millimeters. So, and it's probably down to a bit of creep in the material, maybe tightness. It wasn't, fully tight, or maybe over tight, DT fascia. So, in the best will in the world, your reduction, it may not stay perfectly as it was day 1 post-op. So again, don't quite beat yourself up. It will blot a little bit, but not too much. Okay, thanks very much.
Thank you very much, Matt, for the nice presentation. I encourage all of you, all the attendees, please, if you do have any question, that's the time to type your question right now in the Q&A part.
So I've jotted down some notes down here on my paper here in front of me, just to ask all of you guys some questions. I think there is something really important that maybe some of you just touched on at the end, like Matt, you touched on that, the timing of the acute repair. Does that really matter with you guys? Do you do something to get that done as quick for acute versus chronic? Do you always take the conservative way, even in a grade 5 young active guy, or do you go for the repair? And if you go for the acute repair, whatever technique you are using,
well for me, so for the high grade ones, you know, then I would go for repairing an acute repair, and you know, depending on what you call acute, you know, logistically, where I am in my country, you know, acute will probably take a good 2 or 3 weeks before I'm going to get that patient into theatre.
okay.
So I'm going to fix those. It's those middle grade ones, you know, the sort of the 3s, you know, then I'm going to have that chat with the patient, you know, because the problem is if you fix all of those, there's a lot of those patients would have been completely fine, would have had no pain, no clicking. Yes, it would have been a little bit of deformity. So that's why I have that conversation about, do you want 1 hit or 2 hits, you know, from work? And Ben Kibler did some study at, he called it the sick scapular syndrome. So it's 6 weeks post-injury. If you have scapular dyskinesia on examination, then they're the ones going to do badly. So in other words, you could argue for those middle grade patients, you either fix them if they want it fixing, or I'll give them 6 weeks of conservative treatment, re-examine them. If they've got scapular dyskinesia, I'm probably going to say you're going to struggle here and I'll fix it. If they haven't, we'll run with it. And I can do it. Okay. But whether I do it acute or chronic, my outcomes are the same.
Yeah, this has been already proven. I've just read a study from Alex Zimmerman and Patrick Denard and Philippe Collin, who proved that the acute and the chronic actually do the same if they're operated well. How about you, Shariff? What do you think? What is your cutoff between acute and chronic? You see the patient at 22 days post-op, post-injury, with a grade 5. Would you still do an acute repair, or would you associate reconstruction?
So I have to say this. I think the surgeries are the same for me. I essentially do everybody with what I would do for a chronic reconstruction. I go around the coracoid. I have started using this Kairos implant. So I go up through or around and I go across to the AC joint. So the surgery is going to be the same either way. So I don't believe, it's much like in knee surgery. When you look at a posterior lateral corner, after about a week, you really can't fix those ligaments. So you have to reconstruct it. Same here. When you look at those, especially when you're doing these arthroscopically and you actually get underneath that clavicle, you notice very quickly that those ligaments are completely shredded. So so it's a repair is not, so when you're talking about timing, I think we're not even talking about repair versus reconstruction. I think all of these become a reconstruction. And I think the bigger question is when, if I'm seeing this patient at 22 days and I have the conversation and it's a type 5 and they need this done because they're a laborer or an overhead athlete or somebody else. I mean, most people with a 5, they don't even need to be those things. It's just very uncomfortable and very painful. So I have and so at that point, if I have this conversation and they're all for it, if I can get them in the next day, I saw one yesterday, I'm doing him Tuesday and he's 7 days out. And so for me, it was a conversation and he wants it, I'm going to take care of it. But if it's a type 3, I might wait.
Okay, I understand that the implant you're using now is something like a scaffold.
Mm-hmm.
So you would want the hematoma there, the initial traumatized cells or the actual inflammatory cells in that region. So do you associate something different if it's again, more than 3 weeks off?
So
Or is it just this classical way between both of you? Of course, this question goes for both.
I think for me, and part of it is facility related. And what I mean by that is one of the hospitals I operate at will not allow me to use this product yet. So I'm still doing it with a graft, and I drill my tunnels and go up and across the Mazaka technique and then sew it up and over to the acromion. So I have different options. I can do it a couple different ways. I prefer to use this new technology because I think it makes it for a very similar, if not better outcome with much less morbidity, as well as in all intents and purposes, decreased cost. I mean, I can do this for $5,000 less by doing it with the Kairos implant versus using an allograft. Or there's more of a cost, pain-wise, if I take an autograft.
And from my point of view, with regards to the biology, Ali, yes, at 2 months down the line, we're not going to have that acute hematoma effect.
That's right.
But I'm drilling through the clavicle. I might shave off a little bit of clavicle. I'm doing a clearance around that area. I'm going to get bleeding. Yeah. So I'm actually not too worried. And that histology slide that Shariff showed, that was the guy I put in. He was like a year post injury when I did his operation. He's just a rugby player, came to me down the line, and I fixed him. The reason why we got histology on it is because then he went wakeboarding, and the guy's 6'7" and hit a wave at 40 miles an hour, and he on his shoulder, and it went, and then I explanted it, and even a year down the line following his initial injury, there was plenty of ingrowth and on-growth and biology there. Nice. So that's why that timing doesn't really worry me.
So you've actually solved the chronic acute dilemma with your implant or with your graft, with your synthetic graft. Okay. Yeah. So the next question is, how would you over-reduce? Would you just reduce the joint? Would you do an over-reduction? And if you do that, do you use a tensioner to tension your bands, or do you just tension with hand? Do you maintain with a reduction? Yeah, that's some questions for technical aspect.
So that's a very good question. And I know Shariff, because I've spoken to the guys over in the States. So for the last 2-3 years, I've been trying to tell the company that they need a reduction, jig. And essentially, it's like a Dharmal tensioner. You need to go to tension this down. And I think you probably do need to over tension a little bit, because there will be a little bit of creep and movement, and you don't always get perfectly down to the base of the coracoid. So the thing is going to move a bit. It will. We've got to accept that. We all do. So I think, at the moment in the UK, I have my my scrub just pushed down onto it, push it down with a little bit
hammer.
Yeah, just push it down. It's not very. That I know our American colleagues want a bit of kit for everything. So I know Shariff has spoken, but independently we've had very similar ideas. But yes, a tensioning device for whatever technique you use to maintain the reduction, so that when you're tying your limbs, you're not losing your reduction. Do you know what I mean? You push the clavicle down, and with one hand you're pushing, you're tying. So you're going to lose some of that reduction, aren't you, when you do that quick half hitch tie? So
that's right.
I think that would be very useful. Yeah.
Sure. Let me take another question maybe before I send it off to Usama to take the participants' question. What do you think?
Ali, we need to go through the case first. If you don't mind, then we'll go back to the question. What do you think?
Sure. Let's go.
Okay, so we'll start again with the case. That's the initial reduction was done. Shariff, what do you think went wrong in this case, and what you would do differently to avoid the failure which happened?
So are you able to put the video or the case back on? Can we share your screen?
It's not.
No,
Good.
Sorry, Simon, it's not.
Okay.
I'm just seeing you.
So.
Perfect.
Sharing now.
Yeah.
So
this is the initial. So one of the issues here you have is if you look at the angle, it goes from inferior lateral to medially, it comes out a little at an angle. So if you look through the coracoid, you're probably at about 25 degrees. But if you look at the clavicle, you're pretty much straight up and down. So that C-tap angle we just talked about is very acute. It should be literally on top. They should be two straight lanes right on top of it. So that's probably where some of this started. Plus, these cortical fixation devices we just talked about do have quite a bit of creep in them.
Yep.
And so now if you get an attritional injury to it because it's just suture up against bone, in many of these cases, sometimes when you go back, you'll see that the sutures are ruptured when they fail, or they just absolutely loosen up between the dog bones. So you just got to be careful. And then it also looks like there was an additional drill hole, even more lateral. And I think, so I don't think
that's an internal bracing he did.
Oh, that's the internal brace. Okay. Yeah, I think there's a lot of technology here, but I don't know. I think part of it was, I would say, just positioning of tunnels, which we discussed, that this is one of the main causes, if not the top cause of failure.
Okay, good, Shariff. Matt, do you want to add anything?
Yeah, so also, Saleh, again, it comes back to that thing about the DT fascia and the AC joint. You know, I don't know who did this.
I don't think so. He did.
I'm sure they're very good, but you know, just putting those buttons on and having a nice looking X-ray. But if they haven't formally addressed, because you know, don't forget, sometimes when you have these quite high energy dislocations, the end of the clavicle is just is stripped of any soft tissue, and there's nothing there, is there? Exactly. And it may have been that they did a nice reduction, put the internal brace in, but still there wasn't much covering over the top of the AC joint, and maybe the DT fascia was incompetent, AC joint ligament wasn't reconstructed or reinforced, and hence you're relying on just those tapes and nothing else.
Okay, good. So guys, we'll move on. That's what happened exactly, the failure, okay? Then that's after he did reconstruction using a semi-T graft. So Shariff, what do you think? Why did it fail?
It was not completely reduced. So that's one. And so again, I still think, as I brought up many times in the papers I brought up, much of the stability comes at the AC joint, and not just reducing it and putting some CC ligaments across will it give you a good outcome. You could make this prettier by cutting off the end of the collarbone, but it doesn't necessarily give you the right answer. So I think it needed to be reduced slightly more, but now it's chronic, and so they tend to be more difficult. So going back to Ali's question, I like to do them sooner only because they're easier to reduce. And so the longer you wait, the less likely you're going to get a reduction. And this is months out by now. So, but I think what needed to also be done here is to go up and across and span the AC joint.
Exactly. Okay. So that's what happened till November, like 9 months post-surgery. Patient is unhappy, and as we saw, he has a limited range of motion, which is affecting his activity. As we mentioned, he's a pilot and he cannot join back his job because all of overhead activity. So Matt, what would you do in this situation now?
So the important thing, can we just go back 2 slides, Usama?
Okay.
Yeah, there. If you look at how they've obviously gone around with a bit of semi-T, and there's 2 tunnels through the clavicle now.
Exactly, that's what we
are very, very wide. So that means that there's been motion. So that, or there's infection, of course. You know, we've always got to rule out infection when we see widening of tunnels. But it's probably, if there's no infection, it was mechanically not
stable enough. Yeah.
Stable enough for any biology to happen. I know I keep harping on about biology, but you know, all these things we do, we are just bringing a collarbone down, and it's got to heal and stiffen up and tighten there. So in my hands, I would have liked something, you know, high tensile strength, tape there. And I know that the one that I've been looking at, 2,500 newtons, it's the only worry with revision surgery, the guy's got a hole in his coracoid now. If I do a loop around the coracoid and there's those big holes in the clavicle, this is not good. And of course, even if I did my technique, the clavicle might fracture, the coracoid might fracture. You got holes everywhere in this clavicle now.
Okay, so that's his clinical scenario as we saw. We'll move on. What is next, Matt?
So rule out infection, number one.
Good.
Make sure he's it's one of those things that is it good enough for him? I know the answer is no, because pilots need to have that. There's a lot of buttons in a cockpit overhead, so they need to have that forward flexion, which he clearly hasn't got. But I would still, I'd rule out infection, and I'd rule out infection, and I'd rule out infection.
Any further images do you want to request?
CT, yeah, CT.
Yep, exactly.
So I'd scan in to look at what's going on. I suspect that the top of the clavicle is now bald. I don't think there's anything attached to it at all. And Sharif said that although I don't like the hook plate, it has got
a good indication
in revision cases. I'd be worried about slinging anything more around the coracoid and over the top or through the anything more through this clavicle. I think we're going to have bits of clavicle floating around.
So graft, would you take a graft, semi-T or allograft?
I would, and I know what you've done, and I actually, in this particular case, I think it was a smart move, because I think any more over the top or through procedure on his clavicle, I think would have probably failed. I think his clavicle would have fractured. Those holes are very big in that clavicle. They must be 9 mil, and the clavicle's not big, so you have 2 9 mil holes, and you're about to put something else over the top.
Even if
I know you guys in US are a fan of allograft. Would you use an allograft or autograft?
I wouldn't use.
You think there is any difference?
For simplicity's sake, it's the allograft, and we have plenty of it. But in this particular case, I would not. No matter how hard, I'd be worried to reduce this just pushing down to fracture it. So if I wanted to reduce this, whether I went through those tunnels or went around and tied the graft over it, I would still be concerned. So I would try to avoid any graft here, only because of the integrity of the clavicle.
Okay, good. So let's move on, because we have a lot of questions. Anyone will scope this patient?
Just to remove the button, maybe.
No, I scoped him to rule out any intra-articular concomitant injury. I looked at the slab, looked at the subscap and supraspinatus. Just 2 minutes scope, ruling out any associated injury intra-articular. Of course, before surgery, we ruled out infection completely. We did a CT scan for him. Unfortunately, I didn't load the CT scan. And that's what I did, which I do for all my chronic cases. I loop the graft around the coracoid. I don't drill hole the coracoid, and I don't drill hole the distal end of the clavicle. I just make a loop around the distal end of the clavicle, just tie it with a suture together, make one short limb, one long limb, and the long limb is going to reconstruct the superior AC ligament. Then before I put a temporary K-wire to get a good reduction, check with the C-arm. I tend always to do a bit of over-reduction. Then I use a hooked plate. I'm a fan of using a hooked plate in the chronic cases, which I've seen a lot, especially in Egypt when I'm operating there. Then I suture this limb down to the bone, down to the acromion. After just preparing the bone bed, like exactly what we do in the greater tuberosity when we repair the cuff. And That's an intraoperative photo. It's not for this patient. It's right shoulder. It's a different patient. But just to show you how the graft can go in front of the hooked plate to be sutured to the superior border of the acromion. That's intraoperative X-ray to check the reduction, to check the position of the plate. And then the X-ray immediately post-operative. And then the X-ray 5 months post-operative. The patient start having osteolysis. Yes, that's his range of motion before using the hooked plate. He's doing well, no pain. Then we decided to remove the plate. Plate removal, immediate X-ray. It's not a good quality X-ray, but that's how the acromion looked by the scope. I did a quick subacromion arthroscopy after removing the plate. And that's his X-ray 3 months after the surgery. I excised the small part of the distal end of the clavicle, and he's completely stable right now. And that's his range of motion after removing the plate. And he's back to his job. He's flying now.
Usama, can you go back to the last X-ray?
Okay. That's the last X-ray.
Don't you see that there's a bit of superior humeral migration here? I don't want to shock you, but he's going to come back in a year or so.
Let's see.
I'm not sure
Let's
it's the
wait for that.
incident.
Ali,
Did you check the?
I will defend him. I will defend Usama because the way that X-ray is taken with the Zanka has that 10-degree tilt.
No,
So if that was a Grashy, then I'd give him a hard time.
I would have done the same exact thing. You've done exactly what should have been done.
That's an X-ray.
Yeah.
Do you think?
I think that there is an element of infection, Usama. There must be. This progression is super. There must be some.
We took tissue culture even on the surgery. We sent the 3 culture for culture and sensitivity. There was no infection. We did all the lab tests before surgery. There was
you did your job, but you know, you never know. Sometimes it's quite.
We did a lot of jobs, so that's what we can do right now. Yeah. I know there could be some element of subclinical infection. You know, the P. acne is the common one and around the shoulder, and it's causing subclinical infection. It's hard to be detected by the lab, but that's what we did. And
so this is just
culture came negative.
I love this. I love what you've just shown because it does really show the downfall of the hooked plate, which is something that is really defended in our region.
See, you can
Some people do still think it is the gold standard, and I think it is sometimes over-aggressive and can cause irritation under the acromion and sometimes a rotator cuff tear, and this is quite a big problem. So just to make sure that people understand that the hook plate is not the best treatment we can offer in an acute, quick fashion.
In acute, I never use it, Ali. Yes, I completely do agree with you. But in this patient particularly and chronic patient in generally, I tend to use it. In this patient, I kept the hooked plate a bit longer because it's a second revision. And I don't want to play with this patient more than this surgery. But in generally, as I've been told from my mentor in Canada, they remove it around the 3 months to 4 months maximum.
That's right. Some patients disappear though.
Yeah. So Ali, would you do anything differently?
No, I think you are completely correct in your mechanism of treatment because it's a second revision. You should go all in. Do whatever you can to try to stabilize this clavicle.
Shariff, any comment?
Yeah, I think this is a great job. This is a tough case because he has no more options after this. So I agree with Ali. You got to go as you got to bring everything. You bring the kitchen sink as we stay in the States. You bring everything and you do everything. I do like how you position the graft. I wouldn't have thought of it that way. So that's great. So you had graft and fixation. Again, I agree with Matt in the sense that the plate for me is a last resort. I don't use it very often, if at all.
And I think that's what Ali was saying. You know, I think we have got so many options now. And traditionally, you know, in my country, you know, people use a lot of plates, but I think for me, it's a last resort option. You know, I think we've now got so many good options before that. And the main thing with the plate is, if in the acute situation, is, you know, that patient is that patient is going to have a second operation. You know, and you're committing them to that. But we've got so many other options. The other thing that I sometimes do in the tricky case, not that was a bad case of Usama. I think it was a great outcome. I use what I've called the plate, but that's not quite the right word. So I'll do my reconstructions of the coracocalicula ligament with my Infinity Lock, yep. And I'll use a piece of thick human dermal allograft. So I use Arthroflex. I'll fix it to the clavicle, and I'll take it, a bit like Tim Creswell's paper, I'll take it through the AC joint, 2 drill holes in the acromion, and I'll pull it up underneath the acromion. So I've got like a biological hook plate. So I've surrounded the end of the clavicle, fixed it under the acromion, and then tied everything into it. So a biological version, but not for something as serious as that, though.
Okay, so thank you very much. I just want at the end to remind you with our next webinar on 28th, 10 days from today, with Anthony Roni and Samir Hassan on arthritic shoulder. We'll go back to question and answer. Ali, do you have any questions?
Sure. I do. I still have some questions before we take the audience. So I'm wondering about not stack irritation, about stuff that now is being talked about with all these inlaid buttons and drilled in buttons. With such a thick synthetic ligament that you use or scaffold, do you have irritation over the top of the clavicle? And if you do, how do you manage it? Do you close everything?
So the reason why you would get not stack irritation is when you put your drill hole too lateral in the clavicle. Because when you go lateral to the clavicle, you've only got DT fascia. When you go 3 centimeters medial to the unresected end, you're actually on trapezius muscle. So, and I put my knot stack at the back of the clavicle. So I'll come up through the clavicle. I use a button, you don't have to, and then I'll pass my tapes around the front of the clavicle, and I'll tie them at the back. And the reason why I go around the front of the clavicle and tie at the back, because what that does, it rotates the clavicle down. If you take your tapes around the back of the clavicle and tie them at the front, it rotates the clavicle up. So my knot stack is hidden behind and actually deep trapezius, but it's because you've gone medial. If you go lateral, you'll feel it. If you go medial, you don't feel it.
I agree. So, I do the same thing. I make sure I go up and around and tie it in the back. So, and again, one of the things I talked about earlier is make sure that when you take that flap of tissue, you take a big, thick flap of tissue, because that all needs to be repaired at the end. And that's part of the repair.
Yep.
I mean, if you think about it.
Yep.
So you guys do this technique arthroscopically. How many of you associate something for the acromioclavicular joint? And if you do, what is your technique in regard to your implant? So do you cross the ligament across, or do you just open over the acromion and repair like a palto suture?
So I'll open the AC joint ligament, and I'll reflect all that tissue off the clavicle, and I'll do my drill hole, get my tapes up through it, and then I'll pass the tapes through that very important structure, as Shariff said. And once I've got my AC joint reconstructed, then I'll kind of like weave my tapes through the repair and fix them into the acromion. Because once with the device that I've done, once you've done your fixation on the clavicle, you've still got 12 centimeters of tape. So you can weave it through the fascia, you can take it over to the acromion, you can internal brace it.
So I have done it both ways, where I take the extra tape and I sew it into the periosteum of the AC joint once I have a good reduction, sew in the tissue over it. The other thing I recently did is I took it up and over the AC joint, then went subacromial with my scope and drilled a hole down the acromion, and then pass them back down through the acromion up and around to another button, or you didn't even need another button, but you could do it multiple different ways. So I'm trying to see if that one will give me more stability, because now I have 2 different buttons, 2 different knot stacks, a buttress on top of the AC joint. So there's a lot going on, but it also allows for that ingrowth of soft tissue.
Okay,
Do you think that ingrowth is really important at the acromioclavicular side?
I absolutely
Or is it just
do.
Yeah,
I do. I mean, if you think of what we're talking about an AC separation, not a CC separation. I mean, granted, the CC is part of it, but yet we've spent so much time figuring out how to take care of the corticoclavicular ligaments, but we've forgotten about the actual problem, which is at the AC joint. So I think you have to fix the AC joint, whether with soft tissue, whether if you're fixing the DT fascia, whether you're doing both, whether you're doing a tape. I don't care what you do, but you have to address the AC joint.
Okay. I'll just take the last question. I promise it's my last, and then I'll let the floor go. So you've seen in the x-rays of Dr. Usama, this sort of joint.
Yeah.
And this is for me the hardest to reduce. When it's this, it's much easier. But when it's something like this, an acromioclavicular joint that's oblique, do you do something different with your tunnels? Or is it always very close and very short at the most medial part, just above the coracoid?
Yeah, I mean, I think the tunnel, and I know we've both talked about this a lot, but I want that vertical tunnel straight over the middle of my coracoid. And in this guy, I may have fashioned the end of his clavicle a little bit with a saw, because it was a very, very horizontally orientated joint. It's very, wasn't it?
So these are very hard to treat. They never come back.
Yeah,
because you're applying horizontal force on an oblique joint, and I don't know, you should apply a force that is maybe more lateral, or 2 forces. Yeah, I have no idea, but
I think there's something about that inferior AC ligament also that tends to be thicker in those patients I've seen. And those are the ones that, even if they don't have an AC separation, tend to have AC joint pain. And many of those, if you're doing a rotator cuff, are the ones that need a Mumford or distal clavicle excision. So there's something to be said about those. And on those, I might not do much with the acromion. And if you notice on the one before Usama did the hook plate, he did have like a little spur up front that may have also prevented reduction. So I will, on those, do a very minimal distal clavicle excision as I push it down.
Yeah.
What do you think of independent tunnels?
Well, the thing is, with the Infinity Lock, you can do independent tunnels. You can do whatever you want.
Yeah.
So
you don't even need tunnels. You could go up and around if you wanted.
Yeah.
Yeah. Okay.
I just want to thank you very much for being with us today. Thank you for accepting our invitation.
Thank you.
Thanks, Ali.
Bye, guys. Thank you, guys.
Thank you.